Welcome to Pediatric Case Review. Today we will explore Croup, also known as laryngotracheobronchitis, a common respiratory condition in children. This lecture uses case-based multiple-choice questions to help you master the clinical presentation, examination findings, pathophysiology, diagnostic approach, and evidence-based treatment strategies for Croup. By the end of this session, you will be confident in recognizing Croup, grading its severity, and implementing appropriate management. Let us begin this comprehensive review together. Question 1 focuses on clinical presentation. An 18-month-old child presents with a sudden onset of symptoms after experiencing a cold for 2 days. The parents report that the child woke up at night with a distinctive barking cough, along with hoarseness and a high-pitched noise when breathing in, especially when agitated. There is also a low-grade fever present. Based on these clinical features, what is the most likely diagnosis? Option A, viral croup. Option B, bronchiolitis. Option C, asthma exacerbation. Option D, epiglottitis. The correct answer is A, viral croup. This case demonstrates the classic presentation of croup with 3 hallmark features: the characteristic barking cough that sounds like a seal, inspiratory stridor, which is that high-pitched breathing sound, and hoarseness due to laryngeal inflammation. The typical age range is 6 months to 3 years, with symptoms often worsening at night. The preceding upper respiratory symptoms for 1 to 2 days are very characteristic. This clinical triad makes viral croup the most likely diagnosis in this scenario. Question 2 addresses clinical severity assessment. A 2-year-old child presents with an occasional barky cough and hoarse voice. The parents note that the child only makes a high-pitched breathing sound when crying or upset, but breathes normally when calm. On examination, you observe no chest wall retractions, normal air entry bilaterally, and the child appears comfortable and interactive. What is the severity classification of this presentation? Option A, mild. Option B, moderate. Option C, severe. Option D, impending respiratory failure. The correct answer is A, mild severity. This child demonstrates features consistent with mild croup, which has a Wesley Croup score of 0 to 2 points. The key findings supporting mild classification include stridor only with agitation rather than at rest, absence of chest wall retractions, normal air entry on auscultation, and normal level of consciousness with good interaction. Children with mild croup can typically be managed as outpatients with a single dose of corticosteroid and close follow-up instructions for parents. Question 3 examines clinical assessment. A 3-year-old child presents with typical features of croup, including the barking cough and hoarse voice. You are monitoring the child closely to determine if the condition is worsening. Which of the following examination findings would signal worsening severity and progression to more serious airway obstruction? Option A, stridor at rest. Option B, hoarse voice. Option C, normal oral intake. Option D, intermittent barky cough. The correct answer is A, stridor at rest. When stridor becomes audible without agitation or activity, it indicates significant airway narrowing and correlates with increasing obstruction. This finding typically progresses to moderate or severe croup and is often accompanied by suprasternal or intercostal retractions and visible respiratory distress. Children with stridor at rest require prompt medical intervention, close observation, and consideration for treatments such as nebulized epinephrine. This is a critical warning sign that should never be ignored. Question 4 focuses on radiographic findings. A 2-year-old child presents with a barking cough and stridor. The clinical team decides to obtain imaging to support the diagnosis. An anteroposterior neck radiograph demonstrates tapered narrowing of the subglottic trachea, creating a distinctive appearance. What is the name of this classic radiographic sign? Option A, steeple sign. Option B, thumb sign. Option C, sail sign. Option D, meniscus sign. The correct answer is A, steeple sign. This finding represents subglottic narrowing due to mucosal edema, which is best seen on an anteroposterior neck radiograph. It creates an inverted V shape that resembles a church steeple. However, it is important to remember that imaging is not routinely required for patients with typical croup symptoms. Radiographs are generally reserved for cases where the diagnosis is unclear, the clinical course is atypical, or to exclude other causes such as foreign body aspiration or bacterial tracheitis. Question 5 explores the underlying etiology. A toddler presents during the autumn season with sudden onset of barking cough, inspiratory stridor, and mild fever. The symptoms began after a brief upper respiratory illness. Croup can be caused by several different viruses, but one virus accounts for the majority of cases. What is the most common viral cause of croup? Option A, parainfluenza virus. Option B, rhinovirus. Option C, parvovirus B19. Option D, cytomegalovirus. The correct answer is A, parainfluenza virus. This virus, particularly types 1, 2, and 3, is responsible for the majority of croup cases, with type 1 being the most common. Parainfluenza typically causes seasonal outbreaks in autumn and early winter. Other viral causes include influenza viruses A and B, respiratory syncytial virus, adenovirus, and occasionally measles virus in unvaccinated populations. Understanding the viral etiology helps explain why antibiotics are not effective and why treatment focuses on reducing inflammation. Question 6 examines anatomical pathophysiology. The clinical hallmark of croup is inspiratory stridor caused by airway narrowing. While croup can affect multiple areas of the upper airway, there is one specific anatomical region that is primarily responsible for the symptoms. Which anatomical site is the primary location of pathology in croup? Option A, subglottic region of larynx and trachea. Option B, epiglottis. Option C, intrathoracic bronchioles. Option D, alveoli. The correct answer is A, subglottic region of the larynx and trachea. This area is the narrowest part of the pediatric airway and is completely surrounded by the rigid cricoid cartilage, which cannot expand. When viral inflammation causes mucosal edema in this fixed space, even small amounts of swelling significantly narrow the airway diameter. According to Poiseuille's law, resistance increases exponentially as diameter decreases. The turbulent airflow through this narrowed segment produces the characteristic inspiratory stridor we hear in croup patients. Question 7 addresses diagnostic workup. A 20-month-old child presents with classic symptoms of mild croup, including barking cough, hoarse voice, and occasional stridor with agitation. The child is well hydrated, feeding normally, and comfortable at rest. The physical examination is consistent with typical viral croup. What is the best next diagnostic step? Option A, clinical diagnosis, no tests. Option B, rapid viral panel. Option C, complete blood count and cultures. Option D, computed tomography of neck. The correct answer is A, clinical diagnosis with no tests required. Croup is primarily a clinical diagnosis based on the characteristic history and physical examination findings. In typical presentations with classic symptoms, no laboratory tests or imaging studies are necessary. Diagnostic testing should be reserved for atypical presentations, unusually severe cases, or when alternative diagnoses such as bacterial tracheitis, epiglottitis, or foreign body aspiration need to be excluded. This approach avoids unnecessary procedures, reduces costs, and minimizes patient discomfort. Question 8 uses the Wesley Croup score for severity assessment. A child presents with audible stridor at rest without any agitation. On examination, you observe moderate chest wall retractions with visible suprasternal and intercostal indrawing. However, air entry is normal bilaterally on auscultation. There is no cyanosis, and the child remains alert and oriented. Based on these clinical findings, what is the severity category? Option A, mild. Option B, moderate. Option C, severe. Option D, impending respiratory failure. The correct answer is B, moderate croup with a Wesley score of 4 points. Let me explain the calculation. Stridor at rest contributes 2 points, and moderate retractions add another 2 points, giving us a total of 4. The other parameters, including air entry, cyanosis, and level of consciousness, are all normal and contribute 0 points. According to the Wesley scoring system, a score of 3 to 7 indicates moderate severity. These patients typically require treatment with corticosteroids and nebulized epinephrine, along with close observation. Question 9 focuses on evidence-based steroid dosing. You are evaluating a child in the outpatient setting with mild to moderate croup. The child has a barking cough, intermittent stridor, and mild respiratory distress. Based on current clinical practice guidelines and research evidence, you decide to administer a single dose of dexamethasone. What is the recommended dose? Option A, 0.15 milligrams per kilogram. Option B, 0.30 milligrams per kilogram. Option C, 0.60 milligrams per kilogram. Option D, 1.0 milligrams per kilogram. The correct answer is C, 0.60 milligrams per kilogram. This single dose of dexamethasone is the evidence-based standard of care for croup of any severity. It can be administered by mouth, intramuscularly, or intravenously depending on the clinical situation. Studies have consistently demonstrated that this dose effectively reduces symptoms, decreases the need for additional interventions, reduces return visits to the emergency department, and shortens the duration of illness. The beneficial effects typically begin within 6 hours and persist for several days. Question 10 addresses management of severe croup. A 2-year-old child presents with signs of severe respiratory distress, including audible stridor at rest, marked suprasternal and intercostal retractions, and visible agitation with increased work of breathing. The oxygen saturation is 92% on room air. What is the most appropriate immediate next step in management? Option A, nebulized racemic epinephrine plus observe. Option B, start antibiotics. Option C, albuterol nebulizer. Option D, codeine cough syrup. The correct answer is A, nebulized racemic epinephrine with observation. Epinephrine works through alpha-adrenergic vasoconstriction to rapidly reduce subglottic mucosal edema within 10 to 30 minutes. It provides temporary relief while corticosteroids take effect. The typical dose is 0.05 milliliters per kilogram of 2.25% racemic epinephrine, with a maximum of 0.5 milliliters diluted in normal saline. Always administer dexamethasone concurrently because epinephrine effects are temporary, lasting approximately 2 hours. Monitor carefully for symptom recurrence. Question 11 examines post-treatment disposition. A child with severe croup symptoms is treated with nebulized racemic epinephrine in the emergency department. After 30 minutes, the child shows marked clinical improvement with decreased stridor, improved air entry, and reduced work of breathing. The parents are asking about going home. What is the best disposition plan? Option A, discharge immediately. Option B, observe 2 to 3 hours, discharge if stable. Option C, admit all such cases. Option D, obtain computed tomography of neck. The correct answer is B, observe 2 to 3 hours and discharge if stable. After epinephrine administration, patients must be observed for potential rebound of symptoms because the medication's effects are temporary. During observation, ensure the child maintains adequate oxygen saturation, has no return of significant stridor, tolerates oral fluids, and remains comfortable. Before discharge, confirm that dexamethasone has been administered, provide clear return precautions to caregivers, and ensure reliable follow-up. Stable patients can safely be discharged home after this observation period. Question 12 explores complications. A child recently treated for viral croup returns to the emergency department. Now the child has high fever above 39 degrees Celsius, appears toxic and ill, produces thick purulent secretions from the airway, and shows poor response to standard treatments, including nebulized epinephrine. What is the most likely diagnosis? Option A, epiglottitis. Option B, viral croup. Option C, bacterial tracheitis. Option D, foreign body aspiration. The correct answer is C, bacterial tracheitis. This serious condition represents a secondary bacterial infection, often by Staphylococcus aureus, following initial viral croup. Key distinguishing features include high fever, toxic appearance, thick purulent secretions, and failure to respond to standard croup treatments. Unlike viral croup, bacterial tracheitis requires aggressive management, including intravenous antibiotics, potential airway support with intubation, and intensive care monitoring. Early recognition is critical because this condition can rapidly progress to complete airway obstruction and respiratory failure. We invite you to join our pediatric case review community on Patreon. By becoming a member, you gain access to all our educational videos systematically organized by body system, making it easy to find exactly what you need for your studies. Additionally, all presentation slides used in our videos are available as high-resolution images, allowing you to review content at your own pace and practice the multiple-choice questions independently. For complete details about membership benefits and subscription information, please comment below this video and we will message you directly. Thank you for completing this comprehensive review of croup. Let us recap the key takeaways. First, recognize the classic presentation, barking cough, inspiratory stridor, and hoarseness in young children. Second, grade severity using clinical assessment in the Wesley Croup score. Third, treat with dexamethasone 0.60 milligrams per kilogram for all patients, and add nebulized epinephrine for moderate to severe cases. Please follow Pediatric Case Review channel for more informative medical education presentations. If you have any questions or topics you would like us to cover, please comment below.